then some methods that were used to collect this widespread data, finally the results, conclusion, and then I'm going to give the critical analysis of the paper, and then we're going to discuss the future aspects and what further research topics can be evaluated from this study. So talking regarding the background, why was this study conducted? One must ask, because we just don't go on and conduct a study. We first have a rationale, and why do we conduct a study? We all know that COVID-19 pandemic, this dreadsome pandemic that has affected us in multiple ways. So it is basically a global health burden. And again, it is of an urgent concern, something that we must deal with right now and right at this moment. We must know that COVID-19 is not only simply an infection, which is just coming and going like the cold and flu we have. It basically has some long haul symptoms associated with this. These symptoms are sometimes referred to as post COVID-19 syndrome, and the name is quite explanatory. We also must know that since the pandemic started in 2019, by at the late 2019, the data on the neurological signs and symptoms has been very inadequate. And not only is it inadequate, it is not unified. So there were multiple resources from different locations. So there is a need for us to basically unify this data, to look at it from a bird's eye view and to have a better understanding of it. So basically for this study, we use the National Institute for Health and Care Excellence guidelines. What does these guidelines state? These guidelines basically state that the prevalence of the COVID-19 symptoms for more than 12 weeks after the infection, and these symptoms are not explained by any other pathological or etiological agent. So in this case, there is no known cause for this, and they have been persisting for more than 12 weeks or 3 months. And this is basically used to evaluate the prevalence of neurological and neuropsychiatric symptoms in the patient. So last but not the least, we must discuss like whom was the data reported on. So number of people were included in the study. There was about 10,000 people who were included in the study, and this was reported on patients who were COVID-19 positive. So let us look at the methodology first to understand this article. So basically, this is a review article, and we are well aware it is a meta-analysis of a number of different studies that were conducted. So total number of studies, 18 studies were included, which included few prospective, retrospective studies, some cross-sectional studies, and case controls studies as well. And number of patients was about 10,000. So we see we have a quite huge sample size in our study right now. What were the criteria for including these 18 studies? Number one, they must satisfy the NICE criteria, which I already stated. Prevalence of symptoms for more than 12 weeks without any explanatory reason. Then the prevalence of these symptoms. What are the symptoms we are discussing on? We're discussing on the neurological and the neuropsychiatric symptoms. And the second part of this is that those individuals must be COVID-19 positive. The third is that the cohort size should be more than 50 patients. So obviously, more the cohort size, the more accurate, the more easy we are able to understand these prevalence of these conditions within the population. And finally, these studies must be able to describe the hospitalization status during the acute phase. What do I mean? It means that each of these study must describe each of these patients' hospitalization status. That is, whether they were present within the community, whether they were hospitalized, or whether they were present within the ICU. So these must be stated within the study. Now, again, we also have some exclusion criteria of why the study was not included, because obviously not 18 studies are present. There were multiple, even thousands of studies that are present here. So the exclusion criteria include case reports, any editorial, commentaries, meta-analysis, review articles, any animal studies, and the last but not the least, pediatric population in less than 18 years of age. Now, again, we cannot comment why did the authors decided to remove it, but we must be aware of why certain studies were not included. And finally, any studies which did not give us the data on the neurological or the neuropsychiatric symptoms, obviously these are not useful to us right now because we are dealing with those symptoms. So in this case, finally, we must know some of the statistical methods that were used. We must be just aware of the names, that is this random effects model. Then in order to calculate the uh, various statistics. There was a Sidnick Johnman estimators for tau, then heart tongue nap adjustment, and finally some chi-square testings and various other methods like standard deviation, confidence interval, odds ratio were used, and these were made using this statistical program, that is a statistical software package Stata. And again, this is just some program here in this case. Finally, this is just what we needed to know. Identification was done for about 1,000 studies, out of which, in the last but not the least, they were included only about 18 studies in this case, which included about 10,000 patients in this case. Let us look at what did we find in the results and what is something which is so interesting. So before we start, we must first look at the baseline characteristics or the demographic data of our patients, which will basically help us understand what or whom are we reporting our data. First but not the last, first and the foremost, we must know that there were about 59% females. So a majority of those patients, of 10,000 patients, 59% were females, and the mean age we can see it is quite elderly. It is about 52 years was the mean age of the patients that was found. Finally, when we discuss regarding the hospitalization status of the patient, we must know that significantly older patients were admitted in the hospital, in which 57 years was the average age of hospitalized patients, whereas 46 years for the patient who were non-hospitalized or not hospitalized. Not only that, we must know that about 51% of the patients were hospitalized, and out of these 51, about 13% patients were admitted in the ICU. So we can see more than half were admitted in the hospital, and quite a chunk of those patients were basically in the ICU as well. And the most common complication, the most common comorbidity associated with our patients was hypertension and diabetes mellitus. And again, this is something which is very common even in our day-to-day lives, but we must be well aware that hypertension and diabetes mellitus was very common. And this again was very common in patients who were hospitalized. These comorbidities such as chronic kidney disease, any pulmonary diseases, hypertension, diabetes mellitus was more common in hospitalized. Again, this is self-explanatory because hospitalized patients are generally much more weaker in this case. Finally, what was the most frequent acute neurological manifestation that was reported? What do I mean acute? Acute, which is reported within a few days or a span of few days after the infection or during the infection of COVID-19. In this case, anosmia, that is an inability to smell, dysgeusia, and head. Dysgeusia basically means distorted taste. So mostly patients will feel they are having a metallic taste or a sour taste or a bitter taste in their mouth. So this was the most frequent acute neurological manifestation that was reported within the patient. Finally, we must know that were symptoms more common in non-hospitalized patients or hospitalized patients. Now, again, this is a very interesting concept because most commonly the symptoms that we report, neurological as well as the neuropsychiatric symptoms, were mostly reported within the non-hospitalized cohort. And it was reported less within the hospitalized patients. But again, there are certain discrepancies regarding it, which we will discuss later on. Let us look at the results that we have here. In this case, we're going to discuss the prevalence of the post-COVID-19 syndrome. And I already mentioned we are following the NICE guidelines, that is a National Institute of Health and Care Excellence. In this case, let's just see what we find. We find that the majority or the big chunk of our symptoms was fatigue. This was one of the most commonly reported or the most prevalent, which about 36% in this case, and we can see here. Not only that, the patients also reported to have brain fog, which is again quite high in its prevalence. They had memory issues and sleep disturbances. So these were certain cognitive dysfunctions that were reported in patients for more than 3 months. Not only that, we must know that we also discuss these symptoms in the time period that they reported. For example, let us look at the next graph here. We report the symptoms as present as acute, that is within a few days of infection. Then there were some which were mid-term, that is from 3 to 6 months, and some that were long-term, which persisted for more than 6 months in our case. So we see we are reporting the neurological and the neuropsychiatric data in two aspects. Number one aspect, what is the most common symptom and what is the hospitalization status of our patient. Number two, we report it on the time duration, and in this case, acute, mid-term, and long-term. So let us look at it. As you guys already, I hope, remember that I mentioned that anosmia, dysgeusia, and headache was the most common acute symptom reported. If we analyze this in the duration table, we see that anosmia did not increase much. Dysgeusia also remained the same. And headache, there was a slight increase in the headache from midterm to long term. But what were the symptoms that had a significant effect? If we look at this um, graph right here, we can see depression, fatigue, insomnia, anxiety, and brain fog. These had a significant increase. Let us take an example, let's just say, of depression. Depression midterm was reported to be about zero point 0.1 in its frequency, and it nearly doubled to about zero point 0.3. Similarly, if we look at, for example, insomnia, which was about point less than zero point 0.2, then it doubled. So there was a prevalence of certain symptoms even in the long term aspect. Now, so this is very important for us to analyze. Why? Because neuropsychiatric symptoms such as depression, anxiety, and insomnia or sleep disturbance is basically not only did they come after the infection of COVID-19, but they tend to persist after long. They don't tend to resolve. So this will help us identify certain gaps which are associated with the infection. So finally, what can we conclude from this study that we conducted? Like, we saw a lot of patients, we saw a lot of studies. What are we able to conclude? Number one thing, we are able to conclude that neurological and neuropsychiatric symptoms are very common components in COVID-19 infected patients, which is well explanatory. I mean, we are discussing it regarding. But of these neurological symptoms, which is the most common? Fatigue and cognitive impairment. Now, this cognitive impairment will include the various terms like brain fog, memory issues, any attention issues, and so on. These were the most common neurologic symptoms reported. But what about the neuropsychiatric? As I already mentioned in the previous slide, that sleep disturbance, anxiety, and depression, these are the most common neuropsychiatric symptoms that were reported. And these tended to increase in prevalence. So they did not resolve after the infection, but they appeared and they tend to persist for a long time after the infection. So, what can we conclude? We did a long study on this. We can conclude that there is further awareness that is basically needed to identify these symptoms, and a research on the interventional strategies must be done so that we are able to identify them earlier on, tackle them earlier in the cases of the disease, and finally have a better prognosis for our patient in this case. But there was uh, obviously certain limitations associated with the disease, which we will discuss after this slide. We must know that why are we basically studying these post-COVID-19 syndromes? This is basically so that we are able to improve the quality of life and we are able to decrease or attenuate the disease burden. Because again, this disease is not only a burden for the elderly age group, but it can affect even the youngest population to that of the middle-aged people as well. So let us have a good analysis of the paper and understand what were the factors that contributed and what were the factors or what were the limitations for the paper. So first things first, we saw that anosmia, dysgeusia, and headache were very common acute symptoms, but they did not persist long in the infection. We saw in the graph that the frequency tended to remain the same, and there was only if a increase, a very slight increase, which was not very important in our case. So about 70% and about 60% patients reported improvement in their symptoms of anosmia and dysgeusia. So we can see that these were common, but they tended to resolve and they were not a huge burden for the patient in this case. Some might ask the question, like, why is there these persistent symptoms? We can explain them, although a rough idea, not yet proven, but on basis of certain biological and psychological mechanisms. What are these? These are certain implicated mechanisms. For example, it has been implicated that certain neuroinflammation that is caused due to the COVID-19 virus that resides within the cells could lead to these manifestations, or maybe some microembolus has formed due to this constant inflammation, or maybe that this virus is affecting the ability of the uh, individual's immunity, which can lead to this manifestation. Finally, what are the psychological manifestations? Psychological manifestations can be varied. For example, we see COVID-19 pandemic has affected us, a lot of us, in psychological as well as social aspects of our life. We are more bound in our homes. There is less social interaction, less meeting with people, death or the loss of the loved ones, and even reduced interaction has led some explanation so as to why these symptoms persist in the patient. Finally, what is the difference between the hospitalized and the non-hospitalized patient? So we see that generally more severe symptoms are being reported in patients who are not hospitalized. uh, so this can be due to varied reasons. For example, non-hospitalized patients generally tend to be younger. So there can be various explanations for this, or the patients who were hospitalized, they received better care in our case. But again, this is something which was not very clearly explained within the paper, so we cannot be able to identify this. Finally, let us look at the ICU admissions due to COVID-19. Now, what is PICS? PICS is basically post ICU syndrome. This is a group of symptoms, group of manifestations that occur to patient after they have been admitted within in the hospital for a prolonged period of time. These can include various manifestations like neurological and certain movement disorders. So we can see that there is a chance that there are some PICS or post ICU syndrome manifestations that we might be confusing with post COVID-19 syndrome manifestations. Although we see that very similarly, PICS reports various neurological manifestations like sleep disturbances, brain fog, anxiety. COVID-19 post COVID-19 syndrome also includes the same manifestations, but COVID-19 syndrome does not include manifestations like movement disorders, PTSD, which is very frequently reported in case of post ICU syndrome. Last but not the least, we must discuss that there is actually this one study by Menges et al., which reports that fatigue is more frequently associated with ICU stay, but not with hospital stay. But when the authors actually analyzed their data within this study, they found that there was no significant difference between patients who were hospitalized or patients who were ICU. Fatigue is in general associated as a post COVID-19 syndrome, although more randomized controlled trials need to be conducted. And finally, we must know that there are certain limitations to the study. What is it? It is the fact that although I'm mentioning neuropsychiatric symptoms, cognitive symptoms, we do not have a very clear cut definition of what is cognitive symptom, what is the neuropsychiatric symptoms. So different authors have their different understandings and they have reported it differently. So as a result, we are not able to identify the exact definition of the neuropsychiatric symptoms, the cognitive dysfunction, and obviously this is one of the major limitations for the study. We also must know, out of all the symptoms that we have reported, something which is very important is again cognitive dysfunction, because it is a very prominent features. It will affect the patient, it will affect their daily life, it will affect the overall quality of their life. So it requires immediate attention and interventional strategies for us to basically report on it. Finally, although I think that the paper did a very good review in terms of describing what is the prevalence of these neurological and neuropsychiatric manifestations, but the paper basically failed to report what is the effect of these symptoms, why or how severe are these symptoms. We just know that maybe the patient has brain fog, but we don't know what is the limit, what severity of the brain fog is there. And this paper also failed to report that how do these symptoms affect the quality of life of the patient. Also, there is just one more analysis from this paper. It said that in hospital settings where more than 20% of patients were admitted to the ICU, they reported more symptoms of dysgeusia, of headache, of cognitive dysfunction, and of polyneuropathy, of anxiety and depression. But again, we discussed that there are various reasons why this could happen. Also, if we look at the frequency, we see which is something very highly frequent is fatigue. And again, we discussed regarding it. There are also certain symptoms like myalgia, anxiety, all of these were reported in our patient. So finally, this is something which I found very interesting recently, which was published in the Nature Journal. It was said that SARS-CoV-2 infection and its persistence in the human body and brain at autopsy. So these authors conducted and they reported on multiple different aspects of COVID-19. One thing they reported is that this virus tends to persist within the brain and within the certain cells of the human body. So this is something very important. Why? This is because if it is persistent, it can lead to a constant state of infection and inflammation within the body, which could likely explain a lot of neurological and neuropsychiatric manifestations that we see in our patient. So this is new, like it was published like 15 days back only on 14 December. So this is something which is very eye-opening and which will require more intervention and more research on our part. Last but not the least, this is just a clip of the paper and this clip of the research article, and we can clearly see that comorbidities of diabetes, hypertension were very high. In the acute phases, patients reported high number of anosmia, dysphagia, headache, but these symptoms did not tend to persist long. Finally, what were the neurological symptoms we discussed? They were fatigue, headache, memory issues, and brain fog. And what were the neuropsychiatric symptoms that were reported? Mainly anxiety, depression, and sleep disturbances. So this is basically to summarize all in all, what were the what is the prevalence of the neurological symptoms, what is the prevalence of the neuropsychiatric symptoms that the patients experience, and how these were related to the hospital admission of the patient and the comorbidities. Maybe we can make a correlation with this in the future, but not yet. So thank you everyone. And if you have any questions, you can simply raise your hand and let us discuss on it.
Sir, Ayush sir, it's up to you.
Thank you. Thank you, Nameera. That was a great presentation. I think most of the things you have covered quite well, like especially the limitations part, I think you have covered very well. So besides that, I would like to comment one thing that when we mention the title, it's best that at that time we should also mention the meaning, like the mid and long term. So that would have been better for the viewers who are seeing this, so they would have understand it in the first place. Other than that, I have few things to say regarding the methodology part. So first is for the as a clinician, in the clinician perspective, if we see that the authors have included, there is an inclusion criteria. If you can move to that slide, please. Yeah, so the hospitalization status is there. Sometimes the length of the hospital stay might not be a true, might not truly reflect the severity of the infection, because this is very common, because many times patients are just admitted just for the observation. So in initial phase, especially in the initial phase of the COVID pandemic, so this was done. And since the inclusion criteria is from, I think, January 1, 2020, so in initial days, they might have included those patients. So this is just like a minor issue, but that's fine. It happens because we cannot be 100% correct. So another one, mainly I am concerned about the quality assessment part. That is very important in this. I think you have not included that. Okay, fine. So quality assessment part is very important, because most of the times we are seeing studies are getting retracted because they are not assessing the bias properly. So we need to assess that. In this study, I think the NOS, Newcastle Ottawa bias assessment tool was used. So just a question for you. So do you know which type of studies are which can be assessed by this tool, NOS?
Actually, I was just going to explain regarding this.
Yeah.
I think you guys can see my screen. First of all, we can see a lot of case control and prospective cohort studies are analyzed in this case. And this Newcastle Ottawa scale basically reports on three aspects. That is, what is the patients that with the compatibility and the outcome, and they have a scoring system for about 9, and a score of less than 6 is considered as a biased study.
Okay, thank you. So like the NOS scale is mainly for the non-randomized studies, that is the case control and the cohort studies. And for the randomized, we have other tools, but there are also better tools. This study could have used some other tools like JBI critical appraisal tools. They are better than this one. So that many there you can find out many literature on the PubMed. You can search there and you can find out that why this tool is why JBI is better than this. There are a lot of studies. So another one like yeah. So one thing that I would like to share with everyone here. Many studies we see the authors write that PRISMA guidelines were used to conduct this systematic review. So is it the right way to present? Do we use PRISMA to conduct the systematic review, or do we use it as a reporting guideline? So these are like two different things. So we must be very clear on this. So any idea, Nameera?
Honestly, I would say no, because this is a very deep and a very insightful question. So
Yeah. So in this study also, though it is from a very reputed journal, so but still the authors have mentioned that the study was conducted based on the PRISMA guidelines. However, actually they should have written that it was the reporting guideline was followed. The PRISMA reporting guideline was followed, and similarly for the meta-analysis, we use the MOOS one. So these are very basic things that we need to be clear, because minor mistakes can bring shame to our publications because it is public and they will judge you for that. Yeah, another very important thing, like you mentioned the statistical tests. So though I would not like to go into detail, and it is not my expertise, but like there are two types of models. There are two types of models that we used: fixed and random effect. So mostly we use the random effect model. So this is a point to ponder for all the audience. So you can go and learn like why we use random effect model. The other things that the statistical tests that have been mentioned in the article, they are great. Except one, like one question I have for you. Why Freeman-Tukey double Ascent transformation was used in our test for the prevalence rate calculation?
honestly, I am not good at this biostatistics, but all I can say is that prevalence is a very simple outcome of people who are already affected by the total number of patients who are affected in this case. So
Yeah. So see, like we have basically in most of the studies they use this Ascent transform, Freeman-Tukey double Ascent transformation, and there are other variants of it too. But we can also use GLMM models or Bayesian models, that is the generalized linear mixed model. So the thing is that because the outcome here, the number of outcomes reported are very less, that is why they have used the Freeman-Tukey one. But if there are like large number of outcomes in the study that we have to measure, or the study size is very large, for example, if we have 200, 300 studies, here we have only 18. So usually the GLMM, that is a generalized linear mixed model, that is used for more than 10. However, it is like mainly used for larger studies. So we need to advocate for that as a researcher. Okay, besides that, another important point that this study was very good in, that they have mentioned two things. First is the Cochrane-Q statistic test, and other one is the I-square. So these both these are separate things, though they are used for the same thing, but they measure it differently. So Cochrane-Q, the Cochrane-Q is used for calculating the heterogeneity, but the magnitude is calculated by using the I-square. So this has been mentioned in the actual. You can just share the link with the audience. If they can just go through the PubMed one and see that like detailed analysis is required, because we all are learning, and so it's best that we search those things and try to learn the statistics, because these days it is very important to be independent data analyzers. Another limitation that I found was the COVID symptom. They have reported like we have only the observational studies, but they have not classified the each study whether the symptom reported whether the symptoms reported were objective or they were subjective. So this is very important, because objective assessment is a totally different thing, and using subjective assessment is a different thing. For example, if we measure anxiety can be screened by GAD, General Anxiety Disorder Scale, or they can be used based on some ICD-11 criteria or DSM-5 criteria. So those two things make a lot of difference, because using it as a clinical diagnosis tool or using as a screening tool, those two are very different things. And in this, the authors have not analyzed that part. Obviously, it is not possible to analyze everything, but that part has also been missed, in my opinion. So I think these were some things that I wanted to share with you. Other than that, it was great presentation. Thank you, Nameera.
Thank you so much.
Thank you so much, sir. Audience, do you have any questions? You can ask in the chat box. So I might ask the Nameera. Yes, Anand Agarwal, you can ask yourself.
Hi everyone. So Nameera, the question is for you. While I was going to the presentation, I had this doubt, like, did they mention the acute and chronic symptoms in like hospitalized and non-hospitalized patients? Like you mentioned that the acute symptoms are more common in the non-hospitalized. So is the reverse true as well, that the hospitalized patients suffered more from the neuropsychiatric symptoms?
So yeah, actually, this is one of the limitations of the study. They did report what were the acute symptoms, but they did not report in chronic patients, which had more patients, like which had more reported symptoms, so either hospitalized or non-hospitalized. So this is a very big, I could say, a limitation, because we don't exactly know which patients are more affected in this case. Also, some limitations include, like, we can see that more females are in this study. We do not know the demographics of these females, and so these are some data which are yet to be clarified.
Okay, and also like in the chronic symptoms, was there any demarcation that the people in the ICU suffered them more? Like you also already mentioned it in your comments that there was no proper demarcation that were there in the ICU, or the study said that all were hospitalized rather than being in the ICU. So was there any clear demarcation about it?
So again, like what like Dr. Ayush said, like initially they actually admitted all the patients. Some might move into the ICU, so we don't actually know the severity.
Yeah, they did not like demarcated them. Okay.
Yeah. So only thing I need to say is that this study also found one more thing, that when more than 20% of patients were admitted in ICU, they had some more symptoms, but something this is very not clear for the study as well.
Yeah, there's no significance. Like I could not see any difference in the data there.
Agree.
Okay. Thank you.
Is anyone having questions? If no one is having questions, I'm going to share the feedback form, which you can give the feedback.
Chandu, you got muted actually.
Thank you. Samsung is got question. Samsung someone, so you can ask yourself if you wanted to, or
Ask them to type in the chat.
Samsung SM, you can write in the chat box so I can ask Nameera.
Nameera, overall, I believe that it was a very fantastic paper that you presented. After reading it, I actually felt like coming to the presentation and just listening to you, because this is one of the common things that we are also facing in the clinics, that people are reporting such symptoms and they have a history of COVID. So it's not easy to, like, should we relate it to COVID or not? And the last thing that you reported with the like the COVID virus found in the brain comes with a question in itself, because currently I come across a lot of cancer patients. So one history that we are taking currently is also of COVID, because we make them immunocompromised. So like we this is just a thinking process, but like we check for HIV, HCV, and like other viruses getting reactivated due to immunocompromised status. Going forward, if COVID stays in the body, then that is another thing to be looked forward to, that should we find it in the body, like is it there, what is the level if it is there. And currently that's not needed. Nothing is like indicated for COVID infection, but if it stays, like herpes stays in the body, then going forward I think there will be a lot of modifications. So yeah,
Absolutely
interesting.
agree with you. And it is very nice that you gave us a clinical perspective in this case. So we can see that there has been increased awareness of maybe COVID-19 persisting within the body.
Yeah. Okay, so guys, I think there is no more questions that are there to be asked to the presenter. So today we just had one presenter, and the next JC is on third Saturday of the month. That would be around 20th January, 20th or 21st January. So do join us again, and all of the people who have filled the feedback form will get the certificates in 7 days time. Any other query you have, you can always ping us on Instagram, WhatsApp, or the email ID. So yeah, and do keep following us. So thank you, everyone. We'll just keep it open for 2 to 3 minutes, and only like the feedback form will not be shared through the email or WhatsApp or any other platform. So please be mindful and fill it your ASAP. Like last JC, we had a lot of questions that we attended the JC but missed out on the feedback form. So that's why I'm just reiterating the fact that we are not going to share the form again on any other platform. So if you have attended it, please fill it ASAP. And we definitely look forward to your responses in the form and see that how do you feel about the JC going forward. Okay, so yeah, we are done with the session. Chandu, you can stop the recording, and we'll be here for just 2 more minutes. And yeah, happy Saturday, happy weekend, everyone.